Hello, everyone. I'm Ron Rolfing, and I'm the Preferred Vendor Coordinator here at ACAP. And I'd like to welcome you to our latest ACAP Vendor Education Series webinar presented by BeneLynk. Our presenters today are Keslie Crichton, Chief Sales Officer, Sean Libby, President, and Vicki Jessup, AVP of Government Relations, all with BeneLynk. And they will be presenting the webinar, How to Minimize Member Disenrollment at the End of the Public Health Emergency. But before I turn it over, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's call, and we will post the slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of the homepage and click on the preferred vendors link. And of course, during the call, you can ask a question at any time. You can do this by clicking on the Q&A icon at the bottom of your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now, I'll pass it over to Keslie, Sean, and Vicki.
Thanks, Ron. Hi, good afternoon, everybody. My name is Keslie Crichton, and I'm Chief Sales Officer for BeneLynk. I'm joined today, as Ron said, by our President, Sean Libby, and our Government Relations VP and Medicaid SME, Vicki Jessup. Based on some of the conversations that I've had with your ACAP plans recently, thought it might be useful for us to get together to discuss and share what we know about the end of the PHE, because it's certainly evolving on a daily basis. And while we've all worked in this industry for a long time, we've really never seen anything like this pandemic, but more importantly, the impact that it's had on our members and our businesses. And since we're a relatively new company, we were founded in 2016. For those of you might not be familiar with us, if you could just bear with me, I'm going to share a little bit of information about who we are. So at the heart of our background, we are Medicaid eligibility and member engagement experts. Some of you that worked in Medicare Advantage over the years might remember a company called Social Service Coordinators, or SSC. That is where all of our senior management and many of our staff met over 2 decades ago. We've worked to help people enroll and retain their Medicaid services and overcome social determinants of health way before we ever heard the term SDOH. And this is all we do. So SSC became part of Altegra Health and then Change Healthcare. And that's when we decided we wanted to build something new. And we've learned a lot about Medicaid over the years, and we formed BeneLynk, really simply put, to be better and to serve better. We wanted to take all of the learnings that we've had over the past 20 years and create new solutions that first and foremost build human-to-human connections with your members, to link them with benefit programs that remove barriers to them living their healthiest lives, but also that drives engagement rates and helps drive ROI for all of you. And today we currently serve over 14 million Medicare Advantage and Managed Medicaid members. And we've helped hundreds of thousands of people to get enrolled in programs that improve their lifestyles and drive increased revenue, risk-adjusted revenue, quality performance for our clients. We currently provide dual enrollment services and Medicaid retention in all 50 states. This is kind of an important note, right? Because as you guys in Medicaid are aware, when you've seen one Medicaid state, you've only seen Medicaid state. So having this ability and this expertise across the entire country, sometimes even down to the county level, is really a key distinguisher for us. BeneLynk is the name that we give our enterprise-wide solution. And all of these different programs can stand alone, but they're really designed to allow for greater efficiency, not only for you, the health plan, right, but for your members when they're combined. So we can integrate programs into one dynamic conversation, and we look for conversations to flow organically to assist your members with programs that are important to them. And in the case of this webinar today, about increasing Medicaid renewals, right, to help your retention of these members post PHE. So I encourage you, as we start talking about our solution elements down the road here, to think about what else you need to communicate to your members when you speak to them. If you're going to be doing retention campaigns and delivering renewal information, think about what else you want to tell your members when you get them on the phone. Because the hardest part of any member engagement campaign is actually reaching your member. So when you do, you really want to wrap your arms around that member and help them with as many things as possible in that conversation and as efficiently as possible. Another thing that I want to point out is we help our clients to identify and prioritize those members most in need. Some of you are pretty big plans, right? And you can't reach all of those members. So we use multimodal communications, but always providing a live onshore advocate to engage, educate, and assist your members. I think having that option to speak to somebody today is really important. I don't know about you, but I get really frustrated and I yell at the IVR menus, right? They don't often respond correctly. You just want to reach out to a live person. So having that option to push one or a text message that gives you a phone number or links you back to an advocate is what we try to incorporate into all our messages. We have over 250 advocates, mostly in our office in Florida, but now due to COVID, they're remote in about 15 states across the country. It really allowed us to cover not only all time zones, but our operations now run from 8 a.m. to 2 a.m., which also turned out to be really important for a managed Medicaid population where you have people working different shifts. And the last thing that I want to just mention is having a platform that supports remote staff is also, a key element of what we do. So it allowed us to recruit staff that understand nuances of different states, that sometimes just a relevant accent, right, can create trust and more validity as well. And I'll just give you one example of this, just with our BeneLynk service, right? We hire about 20% of our staff is a veteran or a military spouse. That having that person call other veterans gives us almost instant credibility and trust because they have that empathy built in to understand what that person went through almost automatically, right? And so our advocates worked with our BeneLynk service to, one, understand and surface solutions, sometimes specific to their veteran status, but also what happens for veterans in an MA population specifically usually is that care that they receive if they're using VA healthcare is hidden from the MA plan. So they're missing the opportunity to have accurate risk adjusted revenue and to close HEDIS and STAR gaps, right? So we then gain that member's authorization, collect the medical record, and deliver it back to that MA plan that they can use for retrospective risk adjustment, HEDIS abstraction, or just to thank the veteran for their service. And that's just one way that we try to hire people that really can engage with your membership better than just having a one-stop shop. So, and the last thing I want to point out is think about if you're collecting other information, how you want to document that. With our Community Link program, we document barriers to care and we map them back to ICD-10 codes. That, for most of our clients, makes it easier for them to systematically use that data across multiple business units or share that with their provider network as well. So at some other time, I'd appreciate the opportunity for any of you to reach out if you want to discuss any of these services for MA plans, dual enrollment, or our retention link services. But for now, we're going to jump into our webinar. So I would love this to be conversational, but Zoom makes it a little tough to come off of mute and ask questions. So please, we're going to be monitoring the Q&A. If you have questions, if you have solutions, if you have ideas that you want to share with everybody, please put them in the Q&A and we'll address them as we go through the call. I want to start by just outlining the situation. I realize that we're kind of all aware of what the situation is, but it kind of ebbs and flows all the time, right? Especially lately with CMS guidance. We're going to lay out what the challenges that the situation has posed, talk about some of the state options and CMS guidance from Vicki Jessup, and then we're going to go through just solution elements that we think are really important for you to have within any of your outreach campaigns, and talk about some of the tactics that we use that you might want to incorporate into your strategies. So the situation, everybody's probably seen these numbers. This one came from Urban Institute, but these reports have come out from a lot of different people, right? So 17 million members have increased on our Medicaid rosters since the start of the pandemic, non-elderly Medicaid members, right? And we think that 15 million could lose eligibility at the end of the PHE. A lot of that might be driven by the loss of the enhanced FMAP, which is 6.5% in every state for a Medicaid population, right? So states are going to have some incentives to get people off of their rosters that they think that they can't reach or no longer qualify. And that's really what we want to talk about today. So many of those members will probably qualify for ACA, the marketplace, CHIP, or employer coverage now. And we want to also prevent that coverage gap But today we're going to focus on those that are still eligible for Medicaid and helping them to get through their renewals. So some of you might have attended the ACAP CEO Summit in DC a few weeks ago. This was a huge topic of conversation. So I hope that you find this useful today, but I think it's important to reiterate that the primary goal that CMS stated, that we've heard from many states, and of course from all of you, is to not only get everyone through their renewal, but to prevent a coverage gap. Currently, however, we're not allowed to steer members from a Medicaid plan into a marketplace plan. But Dr. Ellen Mons was at that conference from CMS SIO. When I asked her after her presentation, she stated that she was aware of that friction between the policy and the goal of working, and that they were working on a solution. And Vicki has some updates on that too, some other rumblings that we've been hearing along those lines. I also read the ACAP survey that was there on 15 members that were from various plans. Most of those members were unaware of the MOE, and many were new to Medicaid since COVID and never experienced the renewal, right? Some of them had gone through renewals before. They didn't realize why they hadn't received one. No news is good news. You know, their benefits kept working. And others reported that their states had continued to process the redetermination and they hadn't really noticed any difference, right? The bottom line is a lot of people are unaware that there is going to be a new renewal requirement coming up, and that the process could be the same as before or might be different. So at this point, I want to introduce Vicki Jessup, our head of our government relations. She's going to review the CMS guidance and some state examples as well. Vicki brings a ton of experience, over 20 years of experience as a subject matter expert in Medicaid pathways and application and renewal requirements in all 50 states. I worked with Vicki for many years now and was so excited when she agreed to join me at BeneLynk because she has more information in her head on Medicaid eligibility than I could ever learn and definitely can't remember. Vicki, I know. Vicki ensures that all our BeneLynk processes are aligned with all state requirements. She touches our members, our systems, our advocates for both MA and the CAID plans, right, to keep or increase their benefits. Her team provides direct member advocacy, resolves problems every day, files, denials, appeals, and late responses, and all sorts of stuff to help our members get the benefits they're entitled to. I'm often impressed when CMS actually calls her to share her experiences and to ask for her opinions, but she also maintains relationships with Medicaid staff in all 50 states, the CHIP program directors, Social Security Administration, and she advocates for improvements in federal and state policies for eligibility and enrollment procedures. One more point on her, she used to work for the Wisconsin Department of Health Services as the Medicaid and SNAP eligibility policy chief, and she led the state to streamline enrollment and renewal procedures. So needless to say, she's really well suited to deliver this information. So welcome and thank you, Vicki.
Thank you for that introduction and good afternoon, everybody. So as Keslie said, I have been tracking very closely all of the federal guidance that's come out in terms of resuming normal eligibility and enrollment operations. Has also been in contact with all the states, trying to keep tabs on what they're doing, where they're going, what they're planning. The feds have been moving their cheese a lot. So even though they've had some plans, they've had to revisit some of those plans and may have to revisit the plans again. But themes are definitely starting to emerge, and some information is starting to come out, which I'll share with you guys in a few minutes. The most recent federal guidance from CMS is the state health official letter that came out in August. And it requires states to complete a redetermination prior to terminating enrollment in Medicaid. So even if they've previously attempted to do it and the member failed to respond, they're going to have to try again. So that is a change from the previous guidance that had come out in December of 2020. Another change is the timeframe that states have to get caught up on everything was extended from 6 months to 12 months. So they now have a full year to get caught up. It did reiterate the expectation that states should continue to process renewals now to the fullest extent possible so that they can minimize the backlog after the end of the public health emergency. And also reiterated the requirement for states to resume application processing on a timely basis within 4 months after the end of the PHE. They did say they'd be providing some additional guidance in the months ahead, but nothing official has been released since August. So next slide, please. So also in August, maybe actually in late July, there was 2 different learning collaboration webinars that CMS did with states. They did lay out some expectations regarding return mail, made it clear that they want states to make a reasonable effort to locate the beneficiary. They also laid out a lot of detail around what type of mail is being returned. So if it comes back with an in-state forwarding address, CMS said there's no requirement to redetermine eligibility at that point. Medicaid is a statewide program, so as long as they're still in the state, no need to conduct a renewal just because they moved within the state. If somebody moved out of state, they're obviously no longer eligible for Medicaid in that state. So they do have to send notice to the current address they had on file, and they're also encouraged to send a notice to the member's forwarding address. So they're aware that their Medicaid, is ending in the state where they previously resided, and hopefully that will prompt them to apply in the new state of residence. If there's no forwarding address, states are encouraged to try to use other modalities. So to call them, text them, email them, use something other than their address to figure out where they are. Current federal regulations do not require them to do this. They can terminate somebody if their whereabouts become unknown without even advance notice. So CMS also highlighted a couple of pilots. So in these webinars, they did want to put out some best practices that they're seeing in some states. So Montana was highlighted. They are sending a one-way text to members for whom mail was returned. They found that 25% of the members who got that text did respond and contact the state to update their mailing address. And I realize 25% seems low to me, but it was 40% higher rate of address reporting than members who didn't get the text. So they consider that a success, and they're going to continue to use that and also expand it for things like renewal reminders, or we need documentation, verification, etc. CMS also highlighted Virginia's as a best practice. They're using the National Change of Address database monthly, as well as Address Doctor, to try to make sure that the contact information they have for their members is current. Virginia also sends rosters of their member addresses to the Medicaid MCOs, who can cross-check against their records and identify discrepancies. So there's two-way communication with MCOs, and that's something a lot of states are doing or will be doing to try to make sure that they can reach folks when it's time to renew. Next slide, please. Kaiser also released a findings from 50 state survey. Most states indicated that they are renewing Medicaid coverage when they're able to do so automatically through electronic data sources. This is something states are required to do anyway. They're supposed to try to renew eligibility using existing sources and only require member participation if they can't verify that the member continues to qualify. And there's a lot of variance in terms of how many renewals are done automatically versus requiring active participation from members. So just a couple of examples. Arizona said about 75% of their renewals can be done automatically. Colorado is 85%. But those, I think, are the exceptions and not the rules. But I know states are working towards being able to do more of this. 2/3 of states are currently sending renewal forms when they can't automatically renew eligibility. So they're trying to get members to complete the process, send in the documents, return the paperwork, so that if they do and they continue to qualify, the states can push out that certification another year and remove them from the backlog. However, if members don't respond to these requests, they obviously can't terminate their coverage just yet. 1/3 of states reported that they have established new 12-month certification periods if they're processing a change or a renewal, and that results in a new eligibility pathway. 1/3, and hopefully this number will increase as we approach the end of the PHE, but 1/3 said they were continuing or planning to take proactive steps to update member addresses. Like I said, hopefully there'll be a lot more than 1/3 by the time we get there. And some good news, most states reported that they are staying current on new applications. So we're hopeful that will potentially give them additional resources to get caught up on renewals. So CMS did provide states with planning tools, very detailed, to make sure that they're thinking, about everything, looking around all the corners. They're required to develop a plan, but they aren't required to share it with CMS or get approval from CMS. They just have to make them available to CMS upon request. Also this summer, when CMS was doing the training for states on best practices, they highlighted Virginia, another pilot program. They partnered with one MCO, trying to increase the responsiveness from members to completing the renewals. They gave a list of the members who didn't respond and couldn't be renewed automatically to the plan 2 months in advance. And then the MCO conducted the outreach. So they mailed a postcard, sent a text, and made a call. They found this to be extremely successful. The MCO was able to, the MCO contact prompted these members to respond to their renewal and get it done. So they're absolutely planning to continue this and expand it to additional MCOs. Wisconsin is a state that has been very transparent about their plans. They meet monthly with stakeholders to share what they know at the time. And they have shared that they do plan to take the full 12 months. They absolutely plan to partner with Medicaid MCOs and are even considering allowing MCOs to update member contact information directly in the eligibility system. So that would be a big change. They would, instead of just asking members to report the change to their eligibility worker, they could go right into the system and update a phone number or an email address or an address. So that's not final, but they're certainly considering that and looking to, make sure that they can do that if they can. They also have prioritized the populations that they're going to target for renewals. They sort of separated them into 3 groups. Don't expect that to change, but I'll be keeping tabs on everything. And they're also looking at ways to increase the, ex parte or administrative or automatic renewals, as are a lot of states. And states also during this time have been busy redesigning renewal forms. Colorado just overhauled their renewal notices. I think they look great. California did as well. So I think states are making an effort to make these forms more user-friendly, provide more options for members to get them done. Another example from Colorado is that they're implementing telephonic signatures. They hope to be done with that in February, and that would allow members to be able to renew their eligibility telephonically and sign it telephonically. It wouldn't require them to sign a piece of paper and get that back. So that's exciting. And Colorado also, a couple of states have started to release numbers. So Colorado announced that between 500 and 530,000 members that are currently enrolled appear not to be eligible at this time. Of course, they're going to do a redetermination, but that's how many people they think may no longer qualify for Medicaid, but are currently enrolled due to the MOE requirements. So I've heard Pennsylvania is expecting about 15% of their current membership is potentially no longer eligible. But as Keslie mentioned previously, even members who aren't potentially or don't continue to be eligible for Medicaid, the states will be exploring eligibility for CHIP and trying their best to make sure there's a seamless transition to marketplace coverage. And Keslie teased some additional information. Currently, MCOs aren't allowed to outreach to members when they are no longer enrolled in that plan. So if they don't complete their renewal and they get disenrolled from Medicaid and they get disenrolled from a plan, CMS previously has not allowed plans to outreach to those members, even though in all states, there's a 90-day late redetermination grace period for the MAGI population. It's not required for the non-MAGI population, and some states, also allow a 90-day grace period, but unfortunately not all. So I did hear at the National Association for Medicaid Director Conference on Tuesday that CMS is going to allow MCOs to market to previous members that were enrolled in their plan. So if members no longer eligible for Medicaid, but you have a marketplace plan, there is going to be, at least rumor on the street, an option to reach out to members and market to them about the marketplace plan. Next slide, please.
Thanks, Vicki. If we see that in
Oh.
writing, can we make
Yeah.
sure that we share it with everybody? Okay,
Absolutely.
here you go.
So Build Back Better Act reconciliation bill is the latest information that has come out about how states can resume eligibility and enrollment operations. It has not passed the House. I've heard that there may be a vote this week, but then it also has to pass the Senate. But as it's currently drafted, it would phase out the 6.2% FMAP increase and allow states to start resume processing annual renewals starting in April next year. The FMAP is going to phase out and will be completely over by the end of September, but it would be 3% from April to June and then decrease to 1.5% from July through September. As a condition of that increased FMAP during that 6-month period, there would be some beneficiary protections that states would be required to follow. So one of those is that states would be limited to initiating renewals for no more than 1/12 of enrollees in each month for those first 6 months. This should help make sure that eligibility workers and call centers can manage the workload that's associated with renewals and really disincentivizes states from trying to rush through the process as soon as they can, as quickly as they can. States will only be able to act on delayed renewals for members who were enrolled for at least 12 months. So if somebody has not been enrolled at least 12 months, they can't be in that group of the 1/12 each month during that first 6-month period. It would make it a requirement. So the information that CMS provided to states over the summer in terms of best practices for return mail, if this passes, there's very detailed requirements in this bill in terms of state expectations for return mail. So the states would be required to work with MCOs to try to make sure contact information is correct, as well as other state programs. Many states aren't integrated between SNAP and Medicaid. They're, separate state agencies sort of working in silos. So states, those states would be required to coordinate with other programs to try to make sure that they've got current contact information. And in the case when mail is returned without a forwarding address, states would be required to make at least 2 attempts to call the member or contact the member, I should say. And it even specifies it has to be through different modalities. So 2 attempts doesn't mean sending 2 more pieces of mail to the address where they don't live. It would be calling, emailing, texting, and they would have to provide at least a 30-day notice before they could disenroll after the second attempt. It also requires states to provide a lot of key data to monitor the impact on enrollees. So they'd have to report the number of eligibility renewals that they initiated, how many were successfully completed and will stay enrolled, how many they referred to the marketplace, how many were terminated and for what reason. Was it because they were not eligible any longer or because they, didn't follow through with returning a form or paperwork, et cetera. Would also require states to report on call center statistics. So average daily volumes, wait times, abandonment rates, et cetera. So if this legislation passes, we'd no longer have to speculate about when states are going to start, processing renewals and terminating ineligible members again. We know that would start in April. But yeah, we'll see. I'll be keeping an eye.
Okay, well, thank you, Vicki. There was a lot of information. It's complex. It's different by every state. I'm going to pause just for a moment to see if there's any questions yet. Okay, put them in the Q&A. Okay, I'll keep going then. So the challenge, what does this mean to all of us, right? It really hasn't changed that much since before COVID. Medicaid, managed Medicaid has historically had retention issues. We have churn issues. It impacts not only the cost, administrative cost to you and states, but can really have a negative impact on the health and the financial health as well of some of our members, right? there's a lot of issues that we can talk a little bit more about, the changing of mailing addresses and cell phone numbers. There's two that I'm going to focus on: the lack of urgency and value that are perceived by members, and lack of awareness. They kind of tie together. We did focus groups a few years ago, and there was really some startling facts that came out from, we did an urban area in New York, and we did a rural area, and we divided people into different groups. We had duals, and then we had ABD Medicaid, we had women with children, and so forth. But one of the big things that they all said was, make sure that you're using your data correctly. If you know I have multiple kids, don't call me 3 times, right, to tell me that all 3 kids have to do their renewal, understand what my household structure is, and so forth. And the other thing that really came out that was striking to me in this focus group was they all knew that they had Medicaid, but none of them knew what plan they had. And again, this was in New York City or upstate New York. They didn't know if they had Emblem or Health First or United, right? They just knew that they had Medicaid. And so I really think that when it comes time for renewal, for members that aren't engaged, that aren't going to the doctors, that aren't calling your customer service line and asking about their benefits, that this poses a big problem, right? That lack of perceived value that they have when they don't need medical care. And there are busy families. They're trying to keep the lights on. They're trying to get their kids back to school in person and make sure that they have their mask before they walk out the door. That person, if you put one more task on their to-do list, like completing a renewal, especially if you're in a state that requires documentation, sometimes it's just going to get kicked out, especially when they know they can get their benefits back when needed. So part of what we do is look to drive value and brand awareness, as well as the awareness towards the requirements for that, and roll that into our campaigns. So this is kind of, worst case scenario, what this tidal wave could look like. And from everything that Vicki's saying, I'm feeling strongly that this isn't going to happen in too many states anymore. But this was the fear even a month ago, right? That states are going to lose that FMAP, and that there was going to be a major disenrollment of members that didn't qualify or hadn't responded to renewal requests. And what we're trying to avoid is that loss of your top line revenue and your profits that go along with that. We don't want, we want to make sure that we're not having pent up demand this year, increased cost, as well as adverse selection of only having the sick members do their recertification, that you don't have this sudden loss of top line revenue and you're staffed for, 10 or 20% growth, and you're losing those members almost overnight. And then we also want to make sure that we're talking about lack of eligibility when we're losing our members, not lack of Recert. And again, increasing that awareness about what the requirements are in your state. So what's the opportunity? No pun intended, but we want to flatten the curve, right? So there's so much opportunity. We need to update contact information. We need to be multimodal and use various different communication methodologies. Listen to what your members say their preferred one is, but also follow through and make sure that they're actually reading it, right? A lot of people say, text me, don't call me, right? Especially if I'm at work. But are they saying it because they really prefer to be texted? To receive a text and respond to it, or are they saying it because it's the easiest thing to ignore, right? So we're trying to minimize the disenrollment of members that still qualify, at the same time improve tenure and brand awareness and value all in one call. If possible, integrate services so that you're improving not only your member experience, your net promoter scores, but also driving any quality or P4P measures that you might have in your state. And of course, we want to lower medical costs. Intuitively, we all know, right, that if you help somebody with housing or eating better, getting more money for food, or keeping the heat on or the air conditioning and so forth, depending on what season it is, that should create a healthier member, right? But it's hard to prove, and it's hard to prove fast enough to often show an ROI for the people that want to see that within our organizations. And of course, we want to drive more preventive care services. So when I think about how you roll that all into one outreach activity, I always called it like the triangle of efficiency, right? Picture like an isosceles triangle, and you have the long side on the left side of that triangle. You want to do as many things for as many members at the lowest cost outreach. So put your text messages and your IVR over there to everybody, but then monitor the effectiveness of those campaigns throughout and save the least number of members over on the right, whether that be, you know, a social worker that visits them at home to help them, or, you know, the example of the home assessment, right? The $400 expense over on the right of that triangle versus, you know, text messaging and email for fractions of pennies on the left. So want to share some elements of solutions, right, that I think that everybody should kind of put into their outreach strategies. And there's a lot here, right? So personalized messages. Everybody wants to have a message that resonates with them. And how you do that and how you go about that, you know, differs depending on what your population is, right? But we really think it's important that you think about how to maximize each touch point with your members to make it personal. Don't use the same script for a female that's, you know, 20 to 40 with kids that you do for, you know, a man that's 55. You want to know different things, and they have different quality measures that you're trying to accomplish in the same call. Use multimodal as we've tried, but monitor the success along the way of text or IVR. We think it's really, really important to always have the option to opt out into a live advocate, right? So always either have a phone number included in that text that they can call, a URL to a website, whatever option that you have, but try to make sure that people have the ability to actually talk to somebody. Integrate services for efficiency. You have a lot of things that you want to tell your members again, but you also have to be, you know, kind of aware of what they want to accomplish. So think about and kind of, you know, ride that fine line, right, between telling them too much and telling them stuff that's really meaningful and effective to them. If you're documenting barriers to care, you're documenting that somebody's pregnant, make sure that you follow through on that. Enroll them in your prenatal program right there on the spot. Get their authorization for email or for text messaging right then and there. If there's an app that you want them to download for a prenatal program or education, you know, give them that Google link or the iPhone link for that app right then. So just think about all these ways that you can identify barriers that they might be having, surface those solutions and document them. In our organization, we use the ICD-10 Z codes to map those barriers back to that so that different business units can integrate that, and you can share it or load it into various systems. Okay, so where's my member? Huge challenge, right? We always have this challenge in Medicaid populations, but looking at some of the census data since COVID, it's gotten worse. So in 2014, millions of people moved every year, about 10% of our population. We know, however, that even more people moved during COVID, and some of them temporary. So before, 40% didn't update their new address with anybody. We think that, especially in managed Medicaid, that could be as high as 60% didn't update it. So your state agencies don't have the right information. You might not have the right information. So think about ways that you can communicate to get them to let you know what that information is, or give them the information and the link that they need to go online and update that within their Medicaid agencies, so at least that they receive those renewal forms. Cell phone numbers are a big one, right? We need to identify who's got a landline as well as a mobile. Most of our population, going back to that focus group we did, 98% had a smartphone in the TANF population, right? So we know that they can communicate and receive text messages, but there's 350 million cell phone numbers in the US alone. And what, we got 300 people, and some of those are kids, right? So which number is the right one to call, and how accurate is that information? And then of course, we have a lot of people that have died in the past 2 years, right? 3.4 million in 2020. Thankfully, not all of COVID, but that information takes a while to catch up with our systems as well. So a lot of challenges here. This is a good area to think about a vendor to help you with that. When we do proactive renewal assistance for duals as well as for a managed Medicaid population, we use dynamic content. And what I mean by that is all the information is state specific, sometimes county specific. So you want to know when the member's renewal date is, where they are in that scheme, what your state's grace period is, how they refer to their Medicaid program. is the online app something different? Some states use an access online feature, right? That's not the same name as their Medicaid program. Know all the options available to your member. Do they want to mail something in? Do they want to fax it? So know what's available and then know what information to give to them. So again, it's about reaching them, introducing, but educating, and then make sure that you have a live advocate to assist them and ask any questions. And same thing with your mailing communication, right? Make sure it's relevant to the state that you're in, and then identifying that MAGI might be different than ABD. So this is an example of Wisconsin. It's Medicaid if we're talking about ABD, but it's Badger Care Plus if we're talking about the MAGI population. Make sure you have the right phone number on there. And I know this sounds like really, cut and paste, but call that phone number before you mail. It's really easy to get a typo that can be a really embarrassing phone number. So try the phone numbers before you drop the mail. And then try to lead with help. Try not to have a conversation that starts with something that you want your members to do for you, because that's often how they perceive it, right? So we like starting our conversation with our mantra to lead with help. And when we started BeneLynk, we knew that SDOH was going to be a key focus for us. And we looked at building a network again and knew firsthand how much of that is. There's a lot of good vendors out there, whether it be Healthify, Unite Us. We use findhelp.org from Aunt Bertha, right? But make sure that you have access. There's 211. There's a lot of free services out there, right? You don't have to necessarily go contract, but that your care managers, your customer service people, whoever might be speaking to your members on this topic, have access so that they can ask their member how their day's going, if they need any help finding or navigating any barriers to care. If you cover extra benefits and transportation, encourage them to use that. If somebody's not going to the doctor because they don't have a ride, be prepared to tell them about your telemedicine visits or whatever you have to offer, right? But offer that help and start with a personal conversation, because it's going to help you gain credibility and trust, or maybe the member's just going to feel obligated after you help them with something to follow through on what you want them to do, which would be that renewal. So again, I'm going to pause a little bit as we come up to the end. Does anybody have any questions on any of these kind of solution elements, tactics? Okay, well, we're going to kind of wrap it up and summarize it here. Again, we're looking for ways to improve your engagement, your education, and facilitate greater renewals post PHE and beyond, right? So looking for ways to have an ROI associated with all that might be able to lower your medical costs by eliminating barriers to them living healthier lives, maintain your top line revenue, or even think about ways to make sure your members are in the right Medicaid program, that they don't qualify for additional services. And of course, we want to improve your member experience so that your membership not only maintains itself, but can grow organically as well through positive referrals and just sound bites out there in the community, right? There's a huge amount of work that we're all going to have to do following this PHE to help our states and our and CMS to be efficient as well, right? And Vicki touched on a lot of that. But I want you to kind of think about ways to target those members that are most likely either to not be aware, those that are likely to not follow through, or those that need extra help. And then use vendors to fill in any gaps that you have, whether it be data or staff or technology or subject matter expertise. Leading with help. It's worked for us for 20 years in a variety of different companies. It's a great way to drive meaningful and personalized conversations and at the same time improve that brand awareness and value, right? And then look to integrate other programs or other things that you want to tell that member, whether it be flu shots or COVID vaccines or getting them to their doctor. Try to integrate that, but as efficiently as possible with elements that are going to drive ROI for you for appropriate risk adjusted revenue or closing gaps in care or improve your care management for those populations. And I think Vicki, you got a few others. If you can come off of mute and you just want to touch about some of the things that these plans can do to communicate with their states or CMS.
Sure. So, a few suggestions. We already talked about this, trying to get authority to contact members after they've been termed, but are still within their grace period. Try to get lists from states of members who they've tried to get to complete the renewal and they haven't responded. If you don't already get them, ask the state for advance notice of Recert dates so you can do that outreach. contact members, encourage them to update their contact information with the state, ask your state to use the full 12 months to return to routine operations instead of rushing it after September. I think just getting a good sense of the state's current operations, how many, what percentage of renewals are they currently doing ex parte, are they doing anything to try to expand their ability to do these automatic renewals, keeping a close eye on this data once it becomes available, their call center statistics, how many people are successfully getting through the process, finding out how many people the state, like Colorado, I mentioned, anticipates about 500 to 530,000 are no longer eligible and will be transitioned to, to CHIP or the marketplace. See if states are willing to share those estimates. There's a lot that I will be doing over the next couple of months to get all that information.
Great, thank you. Well, thank you for all your time that you've spent with us today. I realize your time is valuable. We appreciate you participating in today. And let's see if we have any questions. Of course, follow up with me if you'd like any more information on what we talked about today or any of the other services that we shared.
Yeah, first question today. When do you think states will finalize their COVID unwind plans?
That one's for Vicki.
Sure. So the Biden administration has promised states that they're going to give them at least a 60-day notice before they're going to end the PHE. I think depending on what happens with the Build Back Better Act, which does, provide some certainty with states that allows them to, finalize their plans. But yeah, I would think that, well, not I would think, I know that many states are absolutely working to come up with a plan. Some have, gotten pretty far with their planning already and are sharing that information. Not all states are as transparent as others, unfortunately, but I would think by, April, most states are going to be resuming operations, but we'll see. Unfortunately, there's still a lot of uncertainty.
Okay, next question. You stated that you collect and distribute information on social determinants of health barriers. How do you do that?
Yeah, I can share kind of what our extract looks like, but when we start conversations with our members, we actually have an SDOH kind of assessment that we go through, right? Similar to an HRA, but it's around barriers to care. And when the member identifies different barriers, we map that, whether it be food insecurity or housing insecurity or social isolation. There's ICD-10 Z codes, and they've been recently expanded as well. So whatever the member kind of shares with us in our conversation, we map it back to that Z code. We surface the solution for that particular challenge that they're having. And we also document that so that the solution and the challenge aligns. And then when you share that information, we can put it in an Excel format or whatever. It's easier for people to load into their care management systems or even into, share with their providers and other business units. We have some requests from some plans that are looking for that to be kind of sent in the form of a claim, that would make it even easier to load those Z codes. And so that's something that we're exploring and would love to talk to anybody about if that meets your needs, to incorporate that into like an HRA plus an SDOH assessment and do that in the form of a claim if that facilitates that process for anybody.
Okay, our next question. Do you know when New York City will start excuse me. Do you know when New York City will start doing Medicaid renewals again?
Well, I do know that they pushed out all of the December and January renewals. So anyone whose renewal was due 12/31/21 or 1/31/22, they've pushed those out a full calendar year. So December of 22 and January of 23. They, however, at this point, aren't guaranteeing continuous eligibility during that full year. They're leaving their options open. But if the Build Back Better Act continues, I expect, or passes, excuse me, I do expect that in April they will be conducting renewals again.
Okay. Well, that looks like it takes care of our questions for today. Just a reminder to all our attendees that the slide deck and recording will be posted on the ACAP website by tomorrow morning. I would like to thank all the attendees for taking time out of their day to join us. I'd like to thank Keslie, Vicky, and Sean for a very informative webinar. And with that, I thank you all again and wish you a very happy Thanksgiving next week and stay safe. Thanks.
Thank you, Ron.
Thank you, everybody.
Thanks, everybody.
Thanks.
Thank you, Ron.
Bye-bye.